Yeah, thanks for the question. It's an excellent question, I should have explained this more clearly. So, P53 is the protein, TP53 is the gene. The gene sits on chromosome 17, right? And 17p is the short arm of chromosome 17p. So the TP53 gene sits on the short arm of chromosome 17, so-called 17p chromosome. So we talk about TP53 mutation, the gene being abnormal, and we talk about either TP53 or 17p deletion, because that's the bit of the chromosome that's deleted when you lose p53. Is that clear?
Yeah.
Okay.
Actually, I don't need a microphone. I'm really short, but you can certainly hear me. My question is actually linked to that gentleman's. How and when can you discover whether you have TP53 gene? I've been diagnosed last year.
Okay. So the only time that it makes any difference to what you do is before treatment, and in particular before the initial treatment, because that's where it can access your ibrutinib. Otherwise, you'd get chemotherapy. So that's the most important time to do it. You can do it at diagnosis, even if you don't need treatment, but you're not gonna do anything differently as a result of having that knowledge. It's good practice to do it every time you have new treatment. It might not make a difference beyond frontline, but it's still useful to know in terms of planning and expectation and so on. In terms of how to get it done, we're kind of in transition, I think. So I think it's fair to say that most, if not all, hospitals that treat CLL should routinely send for the chromosome deletion, the 17p deletion. And I'd be very surprised if that wasn't now routinely done. Yours wasn't done. Okay, it may be, if you haven't needed treatment yet, that may, yeah. Okay, so it's not essential that you do it if you don't need treatment. I would expect that if your disease progresses to the point at which it does need treatment, then I'd be very surprised if that test wasn't routinely done. The P53 mutation, or the TP53 mutation test, is not done everywhere. It's much harder to do. And there are lots of pitfalls for the unwary that could result in an unreliable result. And that's the last thing you need. You need the result to be reliable. So there are, I would say, a handful of centres around the country that are able to do this. And if your centre isn't one of them, that centre should be networked with a centre that can do it. And it's certainly something that you should ask about, because there are patients, as I said, that have a mutation but not a deletion. So if you only look for deletion, you wouldn't find the abnormality, and therefore you might miss the opportunity of getting ibrutinib frontline instead of chemotherapy that's unlikely to work very well.
Okay, thank you very much for answering my question. That was the question I just gave on the sheet of paper.
The minimum test before.
No.
Oh, okay.
It was the one about. That was the question. So if you just want to say it.
Okay, right. I'll try and put that. I'm sorry. There's a written question here, which seems to relate to what we just had. Is what are the minimum tests to ask for before treatment? Yeah.
Yeah. So I think it's fair to say that the two P53 tests, I think now are by far and away the most important. And I'd feel very uncomfortable treating anybody without that information. The next most useful test is the immunoglobulin gene mutation status, IGHV status. And again, I think it's probably more widely available than the P53 mutation test, but not as widely available as the chromosome test for 17p deletion. And as I said, if you're about to start treatment and you have mutated IGHV, there's a decent chance that you might do really well with FCR chemotherapy if you don't have a 17p or deletion or TP53 mutation. It also has value at diagnosis in a broader sense. It can kind of help to paint the bigger picture. So patients with mutated immunoglobulin genes just generally tend to progress more slowly, as well as respond to treatment better in the long term. They also tend to progress more slowly, so it's likely to take them longer to get to the point of needing treatment. And this information can be useful to excuse me, some people. So what we do locally is at diagnosis we'll do everything. We'll do the 17p, the P53 mutation, and the IGHV to give us an overall sort of picture of things, and make some predictions, provided the patient wants it, of course. And there are some patients that don't want to know, but most people do. And then when patients then reach the point where treatment's needed, we'll repeat the two P53 tests. You don't need to repeat the other one, the IGHV, because it stays the same throughout the disease's course. But the P53 can change with time, normally in one direction. So you can acquire it. If you don't have it to start with, you can acquire it later on. You rarely lose it, but you can acquire it. So it's important to test it before each treatment episode.
Just another written question, which is related to TP53. The question is, what percentage of TP53 deletion invalidates FCR treatment? Is there kind of any sense of proportion?
Yeah, God, this is an old chestnut. This this came about so years ago. I'm showing my age now. When the MRC CLL4 trial was being analysed, this was a comparison of chlorambucil versus fludarabine versus FC. Danny Kotowski, it was led by Danny Kotowski at the Marsden actually, and I was sort of peripherally involved in the analysis, and where to draw the cutoff in terms of what constitutes, because perhaps I should go back a step. So the thing about P53 deletion, or if you look at any marker in any situation, it's rarely black and white. It's rarely 0 versus 100%. So in CLL, what you often find is that only a proportion of the cells, the leukemia cells, have the deletion or the mutation. So you can conclude that it's not been present from the outset. It's kind of emerged as the disease has evolved. A so-called subclone has acquired the abnormality, and that subclone has sort of expanded, but it's not the entirety of the leukemia cells. It's a subpopulation within the leukemia cells. So then the question arises: how big does that subpopulation need to be in order to be clinically significant and affect outcome? Because if you look really hard, you can find these abnormalities in a minusculely, tiny proportion of cells. So in the CLL4 trial, when we were looking at the effect of we didn't have mutation in this analysis because it was before everyone did it, but it was just deletion of 17p. The patients were split up into groups according to what proportion of their cells had lost the P53 gene on 17p. And that was then related to outcome. So those that had lost, over 50% of the cells did much worse than those that didn't have a deletion. And when you kind of move the boundary between positive and negative down, they found a cut-off of 20% was the sort of lowest that distinguished between patients that did well and those that did less well. So any deletion that affected more than 20% of cells was associated with a bad outcome. And any deletion they found below that frequency didn't seem to have much of an impact. So that was the sort of story at the time. This was going back, 2006 or thereabouts. And then other people did the same thing in other trials, the Germans, for example, and they found, the Germans found that 7% was the best discriminator. And we had all this for immunoglobulin G mutation, didn't we? Whether you call it unmutated if it's less than 2% or 3% or 5%. You've got to put the bar somewhere to categorise patients into two groups. Anyway, the bottom line is that the most recent studies that have involved much more sensitive techniques have shown that even tiny clones actually affect outcomes. So they dominate, even if you've got a really tiny P53 abnormal clone, it's that dominates the clinical picture moving forward. So, these historic cut-offs are a bit phony, really, and probably arose because of the technology that was used at the time, which produced a certain amount of false positive rate. There was a certain, so below a certain threshold, you couldn't really rely on that result being a genuine one. And it's thought that a lot of the patients that had readings of below 20% weren't real. That's why they did well. When you apply more reliable sensitive techniques, any mutation or deletion seems to have an adverse effect. So the short answer to your question is it doesn't matter how big it is. If you find it's a reason to act on it. That said, I'm pretty sure that the inclusion criteria for getting ibrutinib through the blue tech criteria do specify a 20% cutoff. So there's in real life, I suppose, to get ibrutinib, you need more than 20% of cells deleted rather than less than that. But in reality, having less than that puts you in the same bucket as having more, but you can't get ibrutinib. Yeah. So seriously, it's a very serious point that you make, and I think back then, I think there was. I think attitudes to CLL were very different then. I think it was still regarded as, a kind of, a sort of boring, easy disease with no treatment options beyond chlorambucil, and it was all very straightforward. And what's the point of asking for second opinions and so on? I think since then, I think partly due to this episode I've just, because it did ruffle lots of feathers and put the issue on the agenda nationally. I think there's now a much better awareness that CLL is actually a really complex and difficult disease to manage effectively, and certainly locally I'm getting more and more referrals from clinicians that we've trained in our unit, and I know they're perfectly competent, but they are sending me referrals for not just for patients that have been through all the standard treatments and what on earth should we do now kind of thing, but for very early treatment decisions, for frontline therapy decisions, and it's actually it's caused us some logistical problems in terms of accommodating this increased work in our clinic structure actually, but it is a sign, I think, that if this is representative of what's going on elsewhere, it's a sign that the sort of haematological community has finally recognised that CLL is actually a really difficult disease to treat, and acknowledges that treatment decisions sometimes need a level of advice that can't be provided within smaller kind of hospitals. So I don't know to what extent that kind of experience is representative of the wider UK, but my impression is that there are very few sites nowadays that have the same sort of attitude that they had 10, 15 years ago. So I'd be very surprised if whoever is treating you wasn't kind of networked in with a centre big enough for somebody there to specialise in the disease. And also I think doctors are more receptive to patients asking probing questions and expecting not to be fobbed off. And and doctors are becoming more comfortable with the idea of responding to probing questions by asking or referring the patient to a colleague at a bigger centre if they don't have the answer. So I guess my advice to you would be to would be to have that dialogue with your haematologist, and just see, how engaged he or she is. And sometimes, there are colleagues that struggle to engage like this, and patients then ask their GPs to refer, directly, and that we see a fair few patients who come to us via that route. But I think you just have to be not be fobbed off. Don't take no for an answer if you don't get the answers to the questions that you're asking. And I think another good sign of a good healthy unit is the more general way that the unit operates, and whether for example, there's a specialist nurse, whether they have information available, whether they volunteer you information packs, and you can just get a sense of a place by all these other things. But I just sound it out a bit from that perspective, and don't be embarrassed to discuss these issues with your consultant, and don't be embarrassed to request a second opinion if you don't feel that whoever's dealing with you has the depth of knowledge that you personally feel that you require and deserve. Does that sort of, in a waffly way, kind of answer your question? So would you agree with that, Jane?
Yeah, definitely. Yeah.
Again, what I see a lot of is communication not done very well right at the beginning. And that then sets up it just creates further difficulties down the line. So some of the patients I see as that are referred on either by consultants elsewhere or directly from the patients themselves via their GP, they kind of fall into two categories really. There are some, it's all about the medicine. It's all about, balancing this option versus that option, and counselling the patient to make a sensible decision about treatment. But the other category, and there's quite a lot of these, is patients who are a long way from needing treatment, but they're anxious to the point of the disease completely screwing up their life when it shouldn't be, because it's not reached the point where they need treatment. And of course, it's a devastating, piece of news to be given. And wrestling with the whole business of being given a cancer diagnosis in one breath and in the next breath saying you don't need, you don't meet the criteria for starting treatment. So, it's an incredibly hard thing to take on board. And I don't think that's dealt with very well sometimes. And a good proportion of patients I see, the discussion is all around that rather than what treatment to have, if that makes sense. So I think there are two things, and I think consultants in smaller hospitals, they could get better at the communication, and in doing so, just put patients. Just get patients to understand their situation better than many of them currently do.
And can I just got a couple more of these written questions? There's one here about heredity issues with CLL. And this particular individual, they lost their twin brother and father to CLL. So what is the risk of, as it were, your children inheriting this CLL thing? Yeah.
So another great question. So it's very difficult to quantify, but it's certainly known that there are families where there's a clear inheritance pattern going on. It's rarely, what we call Mendelian, where you can sort of map it all out and mathematically, predict the risk in the next generation. It's what we call polygenic risk, where you've got lots of risk genes, all of which contributes a very tiny amount to the overall risk, but they all kind of come together and so on. So that's a very difficult situation to counsel patients about. I guess there are kind of three kind of approaches to this kind of situation. I think at the most proactive level, I suppose. It's possible to see a geneticist and try and understand if there's a diagnosable genetic predisposition. There rarely is, but we've certainly had patients who we've referred to our genetics service who have gone through that process. And then I guess there's a strategy of close monitoring of family members for the development of CLL, and we can obviously do tests these days that can pick up, one CLL cell in 10,000 healthy cells with the MRD analysis in patients that have responded to treatment. I don't think we've ever done that in reality, and I guess the key thing is what you're going to do with the information. So if you were to monitor a relative of somebody with CLL and find a tiny CLL clone that may or may not grow and become proper CLL, what are you going to do with that information? You're going to generate additional anxiety probably because of the uncertainties that go along with that. There's issues for pragmatic things like insurance and all that kind of thing to think about, especially in younger people. These aren't things to go into lightly. In practice, I've never been in a situation where I've monitored a family member where there's a bit of a family history going on for the development of CLL. I can see great difficulties in doing so. So my personal approach, if somebody's really worried about it, we send them to the regional genetics service. Does that answer? It's not a very sort of crisp answer, really. Anything to add to that, Jane?
No, I'd agree with what you said. Yeah, it's an unusual situation. We don't really see it very often, do we? So.
No, but it's absolutely, you're absolutely right that there are families that have more than their fair share of CLL, and the probability is that the kids in that family are probably going to be more likely to develop CLL than kids in another family. But it's how to manage that situation is not at all clear, and I think there are risks of making things worse for the people involved if you're not careful. Because you rarely, I suppose in CLL, you rarely get, I suppose in CLL, because it comes on so slowly, you rarely get into serious bother. And I think preemptively looking for it, you might pick it up, 10, 20 years before it becomes visible in a routine blood test. But how's that going to change anything? Probably not at all, apart from introducing lots of anxiety.
Can you do anything to prevent it in that case? Do you think that your child might be susceptible to just die?
Sorry.
Prevention. If you find it at a tiny level, can you do anything about it? I'm aware of no evidence that you can. That doesn't mean that it's not possible, but I think nobody would give any treatment for an asymptomatic person with a lymphocyte that's so trivial you can't even find it in a normal an ordinary blood count.
Can I just one final question? This question is: if you're a CLL patient and you've got another medical condition or some sort of infection pops up, is there any way you can be fast tracked to get treatment? I don't know whether that's one for Jane or yourself, Andy. Or
So, I'm not
so
sure.
I presume it's both to see your GP in sort of good time. Because certainly if it's like my GP, you have to make appointments a month in advance, or it may be access to hospital care. Would anybody like to clarify on that one? Sorry, yeah.
So, if you've got, say, a certain infection that, and you want to see the GP quickly and then maybe get referred to a consultant.
Yeah.
Takes like months and months to get even an appointment.
Yes. Yeah.
So.
I just wondered.
Yeah. So if you're already in the hospital system, you should have access to the specialist nurse. And if you think there's something going on that could be related to your CLL, an infection, you know, if you start to get recurrent sinus or chest infections, that's very likely to be related to the CLL, then it wouldn't be at all unreasonable to phone your specialist nurse, and then they with an early hospital appointment could be arranged to take it forward. Is that fair comment?
Yeah, I think that's fair. Yeah.
So you bypass the GP if you think it's CLL related. It's a pertinent issue really. What sort of other medical things should the GP be looking after, and what should we as CLL doctors be looking after? And the answer really is that anything that might be related to the CLL we should be looking after really, and that or at least steering. And recurrent infections certainly fall into that category, because that might be an indication that your immune system's failing, and that might sway treatment decisions.
Put our hands together.